Rare craniofacial cleft, anatomical aspects and management principle. Development of face takes place from 3rd to 8th week of gestation. Etiology of facial clefting is not very clear. Incidence is not known. There are two theories of cleft formation: failure of fusion of facial processes, classical theory of Hiss and Tessier, failures of mesodermal migration and penetration by View and supported by Stark. Factors believed to play a role in the pathogenesis of these clefts: infection with influenza virus, toxoplasmosis, maternal metabolic disorders, exposure to teratogenic compounds like anticonvulsants, steroids and tranquilizers, or amniotic bands. Classification are many, but Paul Tessier and Kawamoto in 1976 came out with a more clear classification. Craniofacial clefts have been classified by Paul Tessier into numbers 0 to 14. These numbering are around the orbit like a time zone. Orbit is regarded as the reference since it is common to cranium and face. The clefts located cephalad to the eyelids are mainly cranial and southbound are facial. This time zone principle is helpful in identifying the soft and bony clefts because of the methodical way it is described. The clinical expression of craniofacial clefts is very variable. The defect can be very minor, like a small notching in the lip, or a downward displacement of medial canthal ligament, or a full-blown representation of the enameling. The soft tissue component may not coincide with the skeletal component. It may be unilateral or bilateral. In bilateral cases, each side may be affected by different cleft number. The clefts lateral to infraorbital foramen have more involvement of the skeletal component. Anatomical features of rare craniofacial clefts. Rare craniofacial clefts, Tessier cleft number 0, classified into true cleft, which occurs due to failure of closure of interior neuropore, resulting in widening, displacement of structures of midface. False median cleft tissue is deficient or absent, resulting from an absence or decreased formation of midface. Tessier cleft 0, true cleft, cleft in the central upper lip, can vary from minimal notching to complete cleft. Continues through the premaxilla and secondary palate. Nose is bifid. Columella thickened. Alar cartilages are displaced. Septum thickened, duplicated or absent. Retraction of nose cephalad is seen. The true cleft, Tessier number 0, the nasal bridge is broad or flattened. There is hypertelorism. Diastasis between central incisors. Frenulum is bifid. Continues into the forehead as Tessier number 14. Chorded as midline cleft of mandible or lower lip. Tessier cleft 0, pseudocleft, a false median cleft in which tissue is deficient or absent, partial or total absence of philtrum, columella, premaxilla. Maldevelopment of nose, central proboscis or total aplasia of nose. Nasal septum is vestigial. Tessier cleft 0 or pseudo cleft skeletal features, cleft of secondary palate, orbital hypertelorism, bony defect into ethmoid, extend corded as midline cleft of mandible or lower lip, Tessier cleft number 30. May continue into the forehead as Tessier cleft 14. Associated brain dysgenesis or incompatible with life. Tessier cleft number 1, cleft lip at Cupid's bow, going on to dome of nostril with notching, continues as cranial cleft, Tessier number 13. There is orbital hypertelorism, nasal cavity and pyriform aperture lateral to anterior nasal spine. Septum is paired, cleft through nasal bone, frontal process of maxilla. Tessier cleft 2, cleft lateral margin of Cupid's bow, middle third of the nostril. Defective area is hypoplastic on the affected side. Nose is flattened on the affected side. Nasal bridge is broad. Hypertelorism. Medial border eyebrow distorted. And it continues as Tessier cleft number 2, 12. Tessier cleft 2. The cleft lateral margin of Cupid's bow, middle third of nostril. Defective area is hypoplastic on the affected side. Nose is flattened on the affected side. Nasal bridge is broad. Hypertelorism. Medial border eyebrow is distorted and continues as cleft 12. Tessier cleft 3. Cleft lateral border of Cupid's bow. Base of ala nose pulled up. Coloboma of ala. Vertical distance between alar base and medial canthus is increased. Cleft along the lacrimal groove. Lacrimal sac is prone to infection. Tessier number 3. Cleft lateral border of Cupid's bow. Coloboma of the ala. This is the first rare cleft I saw. Tessier 3. Vertical distance between alar base and medial canthus is decreased. Along NLD groove there is a defect. Sac is prone to infection. Lower canaliculus malformed. Tessier cleft 3 in the ocular region. Coloboma of the lower lid medial to punctum. Limbal dermoids, microphthalmos, enophthalmos, normal eye. Coloboma of upper eyelid, medial third and eyebrow, and number 11 cleft on the cranial side. Tessier number 3, the skeletal features. Cleft between lateral incisor and canine. Cleft palate. Pyriform aperture is involved. Cleft terminates in lacrimal groove. Infraorbital foramen is lateral to the cleft. The skeletal features are: medial wall of maxillary sinus is lacking. Frontal process of maxilla disrupted or absent. Confluence of mouth, nose, maxillary sinus and orbit. Northbound as 11 cleft. Coloboma of upper lid, medial third and medial eyebrow. Tessier cleft 4, soft tissue defect. Cleft lip lateral to Cupid's bow and philtrum. Cleft around the alar base, medial to lower punctum. Lower canaliculus and NLD are interrupted. There is defect in the lower eyelid. MCT present but defective. Tessier cleft 4, again in the ocular region. Coloboma lower lid medial to punctum. Lower canaliculus is disrupted. Displacement of MCT. Limbal dermoids, microphthalmos, anophthalmos, or there may be normal eye. Coloboma of upper eyelid, medial third and eyebrow, and it may continue as northbound Tessier 10. Skeletal features of Tessier 4. The cleft between lateral incisor and canine. Piriform aperture is intact. Anterior surface of maxilla may have a defect. Medial portion of orbital rim and floor shows a defect. And it is medial to infraorbital foramen. Cleft palate may be there. Nasal cavity and maxillary sinus are separate. Posterior canal atresia is often seen. Tessier cleft number 5. Soft tissue features. Cleft medial to corner of mouth and lateral to cleft, Tessier number 4. Cleft of cheek. Defect lower eyelid in the medial and lateral third. V-shaped coloboma lower lid drawn inferiorly. Distance between mouth and lower eyelid is decreased. Tessier cleft number 5. In the ocular region, one may have a normal eye or anophthalmos, microphthalmos, simpliform. Cleft is lateral to infraorbital foramen. Defect in the middle third of floor of the orbit. Orbital contents can prolapse into the maxillary sinus. Cleft 5, skeletal features. Posterior to canine in the premolar region. Anterior wall of maxillary sinus may be defective. Lateral to infraorbital foramen. Middle third of floor of the orbit is defective. Orbital contents can prolapse into maxillary sinus. Tessier cleft 4, unilateral as you can see. Bilateral Tessier cleft 4 in this child. Bilateral Tessier cleft 4 and 5. Tessier 6 represents an incomplete form of Treacher-Collins syndrome. Palpebral fissures have anti-mongoloid slant. Mid or mild coloboma of lateral third of lower eyelid. There is hypoplasia of zygoma. Tessier cleft 7. Males are more affected, also called hemifacial microsomia or craniofacial microsomia or first and second branchial arch syndrome. Tessier 7. Only preauricular skin tags are seen in microform clefts. There is widening of the lip commissure. Macrostoma may extend laterally across the cheek towards the external ear. Maldevelopment of external ear. There is hypoplasia of mandible and maxilla. According to the Prusansky classification, type 1 mild hypoplasia of ramus is seen. In type 2, condyle and ramus are small. In type 3, ramus is reduced to a thin lamina. Maxillozygomatic complex, temporal bone and frontal bone may be hypoplastic. Orbit is often reduced in all its dimension. Tessier cleft 8, there is a zygomatico-frontal dysplasia isolated to orbital area. Soft tissue components are subtle, may be visible as a lateral canthal irregularity, often accompanied with a dermoid or associated with Goldenhar syndrome. Tessier 6, 7, 8 are seen in Treacher-Collins syndrome. It's usually bilateral. It is autosomal dominant and inherited. Anti-mongoloid slant of palpebral fissure, coloboma of lower eyelid, retraction of lower lid, hypoplasia of lashes on the medial two-thirds of the lower eyelid, lateral canthus inferiorly placed, abnormality of hairline, ear defects, skeleton, dysplasia or absence of zygoma. Cleft 9. Superolateral orbit dividing the eye in the lateral third and brow, superior orbital rim and temporal bone show a defect. Tessier cleft 10. Coloboma in the center upper eyelid, mid-eyebrow retracted, irregular cleft, superior rim of orbit, extend cranial base and the cranial bone, frontal bone. Tessier 11, medial eyebrow shows a defect, medial eyelid shows a defect, orbital hypertelorism, encephalocele, cephalad of Tessier cleft number 3. Tessier cleft 12, eyebrow disruption in the medial half, encephalocele, bony cleft frontal bone, frontal process maxilla, ethmoid, hypertelorism, extension of Tessier cleft number 2. Tessier cleft 13, cleft through olfactory grove, widening of cribriform plate, defect in frontal bone, cribriform plate, hypertelorism, cephalad extension of Tessier cleft 1. Tessier cleft 14, there may be dysgenesis or agenesis of midline cranial structures, frontonasal encephalocele, wide displacement of orbit hypertelorism, hypotelerism in agenesis, microcephaly, cyclopia, continuation of midline cleft, 0. Management principles. The clinical expressions of defects are highly variable. Depending on the severity, decision has to be taken whether the defect is compatible with life or not. A multidisciplinary approach is important. Management principles. Soft tissue correction has to be started early. Cleft of tissue involves all layers. A meticulous layer closure should be done. Z-plasty to be used while closing skin defects. Reconstruct anatomically the facial muscles. Wide undermining may be needed. Scar tissue between the cleft has to be removed. Excess tissue can be discarded after proper planning. Bony reconstruction and cleft palate reconstruction can be delayed and done as a secondary procedure. Tissue expander and distraction osteogenesis are useful. Cleft number 9 onwards, cranium is involved. This has to be done along with craniofacial surgical team. preservation of globe for normal vision, moisturizers to prevent desiccation of cornea or do tarsorrhaphy. It is advantageous to reconstruct the cleft of lip, cheek, and eyelid simultaneously to reduce the number of anesthesia, improve feeding, help the growth of orbit if eye is absent. Tessier cleft 0, bifid nose correction, which you can see here. Management of cleft number 3, 4, 5. Basic principles: lower eyelid reconstruction, medial canthoplegy, lowering of ala nose, increasing the distance between medial canthus and ala nose, lip repair, and lacrimal drainage system to be looked after. Technique of simultaneous repair, lower eyelid and lip by Longacker and Kawamoto. Here you can see the skin marking. A nasolabial flap is raised to form the lower eyelid and the cleft lip is repaired. Tessier cleft number 4, you can see after the correction and the growth of the child. Tessier 4 and 5, socket expansion which was started within 3 weeks, repair done on both the sides simultaneously. Tessier 4 and 5, both the sides were repaired and 3-year post-op result is shown. Tessier cleft number 6, hemifacial microsomia lateral cleft, cleft of oral commissure, lateral extent of lip, end of the white roll, measuring the philtral column on the normal side, dropping a line from the medial border of cornea, incorporation of Z-plasty, microtia correction, and mandibular hypoplasia correction. Tessier cleft 7, lateral cleft and macrostoma corrected simultaneously. Basic principles of socket reconstruction: socket expansion, prosthetic eye shell, and bony reconstruction. Only expansion of the socket was done in this case, and finally putting in an eye prosthesis. Tessier cleft 5 with enucleation and anterior staphyloma, reconstruction of lip, cheek, and lower lid, full thickness skin graft to upper eyelid and prosthetic shell. The same child with multiple surgery to improve the appearance. The management of craniofacial clefts is very difficult and challenging. It needs a multidisciplinary approach. Multiple surgeries are needed to improve the cosmesis. Both the parents and child have to be well counseled. A challenge which you can see being reconstructed. Management is very challenging. Thank you.